All right. I know this course has so much information packed into it. You know, your head is like exploding with facts. The breaks are important. All right, I'm going to get going with ophthalmology because there's a lot packed into this next hour. I will speak for myself when I say that ophthalmology is one of the areas where I feel a little insecure about my knowledge base in ophthalmology. And I think there's a couple reasons for that. One is that, you know, your eyesight is a very important thing. It's very high stakes in terms of not missing an important diagnosis. Number two, ophthalmologists have a very, very specialized field and a very specialized knowledge base. And I also know that they happen to have a lot of tools and toys that I don't have in the ER to really see the whole eye. The next point is that my fundoscopy skills are suspect, and I do the best I can like everybody else, but sometimes I'm not sure. And, you know, they use a lot of abbreviations, if you ever look in their notes, that I don't get. So, you know, it makes me feel insecure. So I speak for myself when I say that. The good news is that for the ABEM exams, really what they expect you to know for ophthalmology is pretty basic in the sense that they want you to know about the sight-threatening diagnoses, to recognize them, not miss them, and know what the things are that you can do about them, and recognize the things where you need to call an ophthalmologist right away versus when you don't need to call them right away, and then the really common things that we see that we don't want to mistreat or mismanage. So those are really the objectives of ABEM when it comes to ophthalmology, not that you have to be ophthalmologists. Now, the ophthalmology section, I will also say, is ripe for visual stimuli questions. There's a lot of potential questions that would be associated with a picture of an eye or a fundoscopic exam. So this particular talk has a lot of visual images in it for a reason, because it's very, very likely that they will ask you the question in that type of way. The questions, for the most part in ophthalmology, won't be tricky questions. They're going to be kind of a you know it or you don't kind of question. So my goal in this next hour is to cover those kinds of topics that I think are the targets for the exam, and also breeze through kind of quickly the things that we see all the time. I don't want to spend a lot of time on things that you see every day and spend a little more time on the things you don't see every day. So here we go with ophthalmology. These are the topics that I want to cover in the next hour, things that affect the external eye, the lids, the lashes, etc. Infections of the soft tissues of the eye, periorbital and orbital cellulitis, or preseptal cellulitis, which is periorbital. Those are kind of interchangeable terms. Infections of the eye and the red eye in general, what the differential is for the red eye, including conjunctivitis, iritis, acute angle closure, glaucoma, keratitis, endophthalmitis, etc. We'll talk about patients who present with vision loss and what the differential is there and how to sort those patients out. And then we'll talk about traumatic injuries to the eye and the variety of diagnoses that are there. And in the middle, we have kind of the most painful part, which is to talk about how the pupils work, the neuroophthalmology, the cranial nerves that control the extraocular movements and the pupillary movements, and how to sort those presentations out, patients that have ptosis, patients who have anisocoria, things like that. So that'll be kind of in the middle. So here's kind of your standard, ophthalmologic anatomy slide that goes through all the different layers of the eye. It's kind of there for your reference. I'm not going to walk through all of it. We'll talk about the different parts of the eye as we get to the different diagnoses. So let's start with sort of external eye. These are common things that we see a lot, so I'm not going to spend a lot of time on it. But first, there's blepharitis. Blepharitis is basically inflammation of the eyelid, and kind of specifically the hair follicles of the eyelid. It's usually kind of a chronic staph infection. You see it right along eyelid margins. It's associated patients who have kind of a seborrheic dermatitis type general issue will often have this in their eyes as well. They may complain of it being burning or irritated. It may look a little red. It may look a little scaly. And how do we treat that? Well, we do a little kind of, exfoliation with some baby shampoo, maybe some topical antibiotics if it's kind of bad. And we have to know that, of course, it could lead to keratitis, conjunctivitis, cellulitis if it went untreated. Here's a picture of what blepharitis might look like. You see basically it involves the lid margins. It's sort of diffuse. It's not localized like a hordeolum or a chalazion. And they look a little angry. What would you do with this patient kind of question. Now let's talk about dacrocystitis, another sort of external eyelid problem. This is an infection of the lacrimal sac, the one that sits just infromedial of the eyelid. It's usually associated with a staph infection. Basically, they get a red tender swelling right there. They may have some tearing. They may even have purulent discharge, or they may have obstruction of the tears and they're not draining. There could be associated cellulitis around that area due to that obstruction and that superinfection, and we would treat that again. We're going to start with kind of warm compresses, move on to topical antibiotics, systemic antibiotics if there's really a facial cellulitis or a cellulitis associated with it, perhaps some decongestants as well. Here's a picture of dacryocystitis. It's that tear duct right there in the infromedial part of the eye. Pretty classic. Here's another one that's a little more angry, a little more chronic looking. Sometimes if these don't respond, we refer them to ophthalmology if they've kind of been through all the conservative treatments. Dacroadenitis is another one to be aware of. There are chronic cases of dacroadenitis and acute cases. This is the lacrimal gland that's on the upper eyelid, which we don't see as frequently. If this gets inflamed or infected, it can create sort of a ptosis, a mechanical ptosis of the eye because of the location of this gland. So it's in the superior lateral portion of the upper eyelid. This can be a bacterial or viral infection, but it could also be associated with rheumatologic conditions like sarcoid and Sjogren's and et cetera. It could even be viral like mumps, like the other glands of the face, or even neoplastic if it's been there for a while as well. You can start with your conservative measures, but often these have to be referred for an IND or biopsy if you're suspicious about other etiologies. Where this gland is, again, is in the superior lateral part of the upper eyelid. If you were to pull back the eyelid, you could see inflammation of that gland, or it could again cause sort of a mechanical ptosis with a localized swelling to this area as well. Now, we commonly see hordeolums because these hurt pretty bad, and probably many of us in this room have had a stye in our eye. And the hordeolum is basically a little abscess of the lid margin, usually staph or strep. It's painful, it's red, it's swollen. It could be external or internal. We start again with warm compresses, topical antibiotics, go from there. And that's basically a stye is a hordeolum, okay? And here's a picture. Usually it's often kids, but it can be adults too. Pretty localized, pretty easy to recognize. We see these pretty commonly. The one that could get confused with the hordeolum is the chalazion. And the chalazion is more of a chronic internal swelling. It's a sterile granulomatous reaction, not a bacterial infection of the meibomian gland that lies right back there. Usually they present because it's just annoying. It's not that it's really hurting or that it's inflamed, but it's sort of bothering the patient. And it's usually in the upper lid, often in the mid portion. It can be in the lower lid too, and it's usually a little bit away from the margin. That might help differentiate it from a hordeolum. We can try our conservative measures, but often these need to be referred in a non-emergent fashion for an IND or removal if it's non-responsive. And you should be aware that a lot of these kind of chronic, non-tender type swellings, you have to be also concerned about neoplasms in this area, and you can get a squamous cell carcinoma that can look like a chalazion. So here's sort of a picture of that. You see it's not really red, it wouldn't be tender, it's just sort of, and it's a little bit further away from that lid margin than a hordeolum, and that is a chalazion. Okay, let's move on to the infections or inflammations of the soft tissues around the eye, and this gets us into the periorbital and orbital cellulitis world. So there's really three ways that this happens in terms of getting an infection of these soft tissues around the eye. It can be spread from a local infection, like a sinusitis, something that's sort of contiguous with these soft tissues. It could also be like any other cellulitis from a skin disruption, or in some rare cases, it could be hematogenously spread, and this happens sometimes in little kids where they have a bacteremia and then they seed this part. The causes are often strep staph. There's some other, unusual causes like strep pneumo, especially if it's a hematogenous type spread. And the difference between periorbital, which is also referred to as preseptal, and orbital cellulitis is really an anatomic one. There's a septum, which is why we call it preseptal cellulitis. There's an orbital septum that helps basically protect the orbit from the front part of the eye. And so when you have an infection in the front of the eye, the preseptal or periorbital area, that's different than when you get an infection past that septum in the orbit itself. The orbital septum creates a closed space, which is why orbital cellulitis is a really big deal, because it's in this sort of closed space and the inflammation doesn't have a lot of places to go. So here's a little picture where you see where that orbital septum is. It's this sort of little red line here that kind of differentiates the orbital contents, the orbital space, from the periorbital or preseptal space as well. So if you see a periorbital or a preseptal cellulitis, differentiating this from orbital cellulitis is important. What does preseptal or periorbital cellulitis look like? Well, patients typically don't have a lot of pain. They have some pain, but it's usually kind of minimal, and that's sort of an important differentiator from orbital cellulitis. And in particular, they don't have a lot of pain when you ask them to actually move the globe around. Their extraocular movements are not that painful. They may have fever, they can have some erythema, some edema of the lid. It can look dramatic externally, but the globe underneath, the actual eyeball, should look relatively normal because this is not happening in the orbit itself. If they're a little guy, less than 5 years old, think about that hematogenous mechanism, and you might send blood cultures and do more of a septic workup, especially if the kid has a fever and looks systemically ill. And in terms of antibiotics, we kind of up our game here because strep pneumo was on the list, so we have to think about penicillin-resistant strep pneumo. So we're talking about antibiotics like Augmentin, Vanc, ceftriaxone. That being said, I don't want to imply that all of these patients need to be admitted and need IV antibiotics. Some of them who look very well can be treated with PO antibiotics and have a close follow-up. So they don't all have to be admitted because these are not really septic-looking people. It's really more of a cellulitis in a place that we care about, but some of them can be treated as outpatients if they don't have a lot of comorbidities. Here's a little kid with some periorbital cellulitis. It's puffy, but the kid doesn't look too sick, that kind of thing. Could be PO antibiotics, discharge could come back later for a follow-up. Orbital cellulitis is more of a big deal, and patients will typically look a lot sicker. They will have moderate pain, especially on eye movement, and that would be part of the vignette. The most common way that you get orbital cellulitis is from this sinus spread, and it's particularly the ethmoid sinuses, which are located very close to this orbital space. Typically, the eye looks really angry. They can have kind of dark red lids. They can even have some proptosis because of the inflammation and edema that is created in that orbital space. They should generally not have a lot of conjunctivitis. They may have decreased mobility, and again, the organisms are the same. Why is this such a big deal? Where you have this closed space, and as the intraocular pressure goes up, that basically in turn can reduce the blood flow to the retina, creating ischemia to the retina, and can really threaten the vision because of this closed space. So these patients do get IV antibiotics, and they do get admitted. And in fact, they should even get a CT of their orbit to really look more carefully at that orbital space and to make sure there's not an abscess that needs to be drained, in addition to the cellulitis and the swelling that's there. We also need to know that from orbital cellulitis, there are some pretty serious complications that can happen, including meningitis, which is the most common one, but also cavernous sinus thrombosis could be a complication that could present with cranial nerve type deficits, and they can get orbital and periosteal abscesses as well. So their workup is going to be much different than the periorbital cellulitis. It's going to be labs, CT scan, IV antibiotics, admission, et cetera. Here's a patient with orbital cellulitis. You see sort of the displacement of the eye because of the pressure in that orbital space, and you see that it's not normal externally. It looks red, it looks angry, et cetera. So it's not a subtle presentation. So let's move on to patients who present with a red eye, a complaint of red eye, may or may not have pain. Often they do have pain, and here's sort of a differential for the red eye in general. Conjunctivitis, it could be a foreign body, uveitis or iritis, narrow angle closure glaucoma, which we'll talk about, and keratitis are kind of your main differential diagnoses for a red eye. So conjunctivitis is something we see very commonly, and although in real life it is difficult to differentiate viral from bacterial conjunctivitis, at ABEM General you can do that, and you should know the features of bacterial versus viral conjunctivitis because at ABEM General things kind of present as they're classically supposed to present. So if you're talking about viral conjunctivitis, which is the most common etiology of conjunctivitis, this is really kind of your classic pink eye presentation. Maybe they had a preceding URI, maybe they have some watery discharge, it's usually in kind of one eye, then maybe it spread to the other eye. They may have some nodes in front of their ear there. Their visual acuity should be normal, and what do we do for them? If we knew it was viral, we wouldn't give them antibiotics, we would just say warm compresses, symptomatic treatment, wash your hands, don't expose other people, that kind of thing. And that's the most common cause of conjunctivitis, which is viral. There is a particular kind of viral conjunctivitis, which is a pretty angry viral conjunctivitis called EKC, mentioned here, which is sometimes kind of spreads rampantly through daycares or other places, which is basically really, really bad conjunctivitis. And you may even see corneal stippling on your exam. They could even have chemosis, and they can get bacterial secondary infections, and it usually lasts longer than a regular viral conjunctivitis. And if that was the description, then that would be someone you might talk to ophtho about. This would be much angrier than what you would expect for sort of a general viral conjunctivitis. Now, bacterial conjunctivitis should be described as something that has more of a copious discharge, more of a pus-like discharge, really no adenopathy associated with it. And one association I want you to always remember is if they mention a contact lens wearer, they had contact lenses, as soon as you see the words contact lens, just think Pseudomonas automatically. Contact lens, Pseudomonas. Contact lens, Pseudomonas. That's a very important thing because it changes your antibiotic coverage for that particular case. So if they also describe somebody who has copious purulent discharge, you wipe away the pus and it just streams right back out. you want to think about gonococcal conjunctivitis. And that usually happens from self-inoculation, and it can get more serious than just a conjunctivitis. It can lead to more of a keratitis, and it could even lead to perforation. Those patients who you suspect gonococcal conjunctivitis need IV antibiotics and a culture and a Gram stain and more of a stat consult, because that eye has to be cleared consistently until the sort of copious discharge stops. More generally for bacterial conjunctivitis, if we don't suspect gonococcal, we're going to give them their antibiotic drops every couple hours, and remember that we don't patch conjunctivitis. Neonatal conjunctivitis is another specialized category of conjunctivitis, and like when you're talking about neonatal meningitis, there are different organisms to keep in mind, and there are different sort of time periods that those organisms or etiologies of neonatal conjunctivitis can kind of pop up. So if you have a baby in the first 28 days of life that presents with a red eye, you have to think about things like, if it's in the first day or two, maybe a chemical conjunctivitis as they kind of come out of the womb there. And otherwise, they can acquire things in the birth canal. They can get GC, they can get chlamydia, they can get strep and staph as well. And if you're talking about the first sort of 3 to 5 days, that might be the range for gonococcal conjunctivitis with a lot of purulent discharge. You move on to kind of more the 1 week time period, you're talking about chlamydia, and that's kind of the most common cause of neonatal conjunctivitis. And then you move on, as they move on to their kind of like out of their first month into their first years of life, then we're talking about regular old bacterial conjunctivitis. If it is a chlamydia, remember that chlamydia in the neonatal period is also associated with otitis, pneumonia, specifically kind of a staccato-like cough, and they may have those associated symptoms as well. This baby with really purulent conjunctivitis, you think about that purulence, gonococcal. Okay, moving on to other causes of red eye, we're going to talk about uveitis and iritis. And remember that the uveal tract is made up of really 3 parts. There's the iris, the colored part of the eye, the ciliary body, which is kind of a muscle that's attached to the lens of the eye, and then the choroid. And that lies right behind the sclera, and it provides sort of the blood vessels to kind of nourish the back of the eye there, so the uveal tract. And so we're just going to talk about that as sort of one entity. So when patients present with a red eye, and it's not conjunctivitis, it seems a little bit more deep than that, we have to think about uveitis and iritis and inflammation of this tract. There's a lot of different things that can cause inflammation of this part of the eye. You can have trauma, traumatic iritis, somebody who gets punched in the eye or hit with a stick in the eye kind of thing. You can get infection to this part of the eye, and there can be systemic inflammation, rheumatologic type causes that can lead to uveitis as well. How do patients present? Well, they have a red eye. It's usually sort of a deep ache, not more of a superficial ache. They may have photophobia as well. It can be varying degrees of redness. You'll see often ciliary flush, which is basically the round part right around the colored part of the eye. You get inflammation in that area, which you typically don't see with like a conjunctivitis, which is kind of a superficial inflammation. On your slit lamp exam, classically it's described as having cell and flare, which is basically white cells in this area of the eye. And the most classic presentation is that they have a small pupil, miosis, which is usually from the photophobia that they're experiencing and having this iris sphincter kind of spasm. If the iris sphincter is torn, they could have a dilated pupil, but typically it's a small pupil with uveitis or iritis. How do we treat this? Well, for the pain of this iris sphincter spasm, we can give them cycloplegics. They may need steroids, which we would administer in consultation with our ophthalmologist, and analgesics for the pain. Here's that picture of ciliary flush I was talking about. That increased redness around the outer ring of the colored part is something that happens when you get more of a deeper infection of the eye or deeper inflammation of the eye, and you don't see as much with a conjunctivitis. That would usually be clear. Also with iritis, if you have a lot of white cells involved, you can have a hypopion, and you see this layering of white cells as well. And that is basically just a layer of white cells, just like a hyphema. When you see red cells layering out, this is white cells layering out, and we call it a hypopion. You may also see that in combination with a corneal ulcer. That can happen as well as those white cells layer out in the anterior chamber of the eye. Now, when an eye is really pussed out and there is just, it's almost an opaque looking eye, you have to think about something more than just iritis or a hypopion. You think about endophthalmitis. So this is really when the intraocular cavities of the globe itself get infected. And the most common reason this happens is usually a post-surgical thing. They've just had some kind of procedure on their eye. Now it's all infected and the eye is just pussed out. And that's the majority of cases from an exogenous source. It can also happen sometimes if if they've been poked in like the eye with a stick, something fungal, something grossly infected, and they get endophthalmitis from that as well. Every once in a while, there can be an endogenous cause, but usually it's from some sort of external, exogenous introduction of bacteria into the eye. It is not subtle. The findings are that it looks pretty bad, and they can have a lot of edema and decreased visual acuity, and it depends on kind of what the source is as well. And we're going to go big guns in terms of our bacterial coverage, Vanc, Gent, that kind of thing, and we're going to talk to an ophthalmologist right away. If we think there may be some kind of fungal involvement, like it was a stick or something organic that was introduced into their eye, they may even get fungal coverage as well. Here's a picture of purulent endophthalmitis. You see basically this looks like a pussed out eye. You see a lot of chemosis around it. This is someone who's going to need aggressive IV antibiotics, an emergent ophthalmology consult, and this is very vision threatening. And usually the vignette would be that they had some kind of eye surgery recently, and now you see this. Now, when you have inflammation of the cornea in general, that's called keratitis, and there can be everything from a very superficial involvement of the cornea to a more involved corneal infection. There are a lot of causes of this as well, just like with uveitis and iritis. As the eye gets inflamed more deeply, it can be bacterial, it can be viral, it could be fungal, it could be also systemic things as well. Even drug toxicity or exposure to things like UV light can make the cornea angry. And you will also see this perilimbic flush when you have a case of keratitis. Keratitis, again, because of the epithelial layers of the eye, can be superficial, but it can also progress and get a little bit deeper. So there are more superficial cases. If you were to do a fluorescein stain of the eye, you might see this little stippling, just a little bit of sort of superficial involvement of those outer epithelial layers. And the kind of things that do that are exposures to UV light, for example, welders and sun lamps, things like that. Patients who have a really dry eye, or they were using some kind of drops that cause sort of a chemical irritation of the cornea. And again, contact lenses on the list. And you think about contact lens, Pseudomonas, automatic association. So we're going to try to figure out what caused the keratitis. We're going to see if we need to, get them out of the UV light, et cetera. And we're going to start antibiotics with a pseudomonal coverage. If they do have exposure to UV light, for example, from the snow, like the snow blindness kind of thing, usually that has sort of a delayed onset. It's not usually immediate. It happens sort of a little bit down the road. So there can be often a little bit of a delayed onset from when the actual exposure happened. So here's that kind of superficial sort of stippling I was talking about. You could see sort of superficial involvement of the epithelium of the cornea, and that would be keratitis, and that might be UV, and they may have had some exposure just a few days ago. Here's also keratitis with that sort of perilimbic flush. You just see this sort of inflamed eye. Doesn't look that red, but there's something going on that's making that cornea a little bit angry. You can also have keratitis associated with ulcers if there's a bacterial etiology. And so if you see kind of any white spots on the cornea or any sort of ulceration, of course you're going to presume that's bacterial until it's proven otherwise. And if they have contact lenses, we're thinking Pseudomonas. This is usually painful. It may or may not have some iritis associated with it. If they have some pus in that anterior chamber, it can have a hypopyon. All of these structures are contiguous, so it makes sense that you can have one without the other or one together with the other. And if we're worried about really this kind of a deeper infection, a bacterial infection of the cornea, we're going to reach out to our ophthalmology consult as well to get them at least follow up once we start them on some antibiotics. And they may need IV antibiotics if it's pretty severe, and if it's not, then we can do something more topical and see how it goes. If they have some kind of an immunosuppression, like AIDS, or they're on chronic steroids, you have to also throw into the mix the possibility of a fungal etiology of keratitis as well. And then there's a list of viral causes of inflammation of the cornea, including herpes, not just herpes simplex, but also zoster. So let's talk about them separately, because they're really separate things. If you have a patient who has a picture where they have vesicles around their eye that look more like just traditional herpes vesicles, you can get herpes simplex of your eye. It can be in the neonatal period acquired from mom. It can be a primary outbreak of herpes, or it can be a recurrent outbreak of herpes simplex. And you will see these little herpetic vesicles on the lids, and if you stain the cornea with fluorescein, you should see a classic dendritic pattern. This is one of those classic visual stimuli that you should be able to recognize, and we'll look at that. Often they have decreased corneal sensation if you actually test the cornea and how it feels. And we're going to give them antivirals. We can give them cycloplegics for pain. But in general, for herpes simplex, We don't give them steroids. And the reason is because herpes simplex is going to go away on its own. It's just like it does on the skin, it's going to go away on its own. It's going to resolve. So we don't typically give steroids because steroids can put the whole eye at risk for more of a deeper involvement of this herpes virus, which is kind of unnecessary since it's going to go away on its own. And we are going to talk to an ophthalmologist about making sure they get follow-up. Now, on the other hand, zoster, if you get zoster of the eye, there's a couple additional things to know. Number one, remember what zoster is, trigeminal nerve. But they have a special, again, visual stimuli thing where if they get a little vesicle on the tip of their nose, this is called Hutchinson's sign, and it's kind of a harbinger of the zoster to come. And the zoster to come, that could involve their eye. So recognizing that this tip of the nose involvement is sort of a red flag for, hey, this patient may get zoster of their eye, is something we have to recognize, even though it may not be there yet. Because eye involvement is likely with zoster involvement of this nerve. You can often have lid lesions as well. If zoster gets to a more deeper part of the eye and you have more of an iritis, you may need steroids in the case of zoster, but again, you're going to consult with your ophthalmologist and talk about that. But zoster can quickly proceed to more of a deeper infection of the eye than the herpes simplex. They're going to get antivirals, they're going to get pain meds, and you're going to talk to an ophthalmologist. So let's look at a couple of these visual stimuli. Here's a patient who has some of these classic sort of HSV vesicles around the eye. And so that would be herpes simplex of the eye, that you'd have these kind of vesicles and maybe some superficial involvement of the eye itself. If you were to do a fluorescein stain, this is that classic sort of dendritic branching pattern that you can see with herpes. Now here's a patient who's got zoster of the nerve here, and so you see that's kind of the classic shingles of the eye, essentially, and you have that tip of the nose, and that may be the first thing that they presented with, which would be called Hutchinson's sign. And there's a picture there. His eye isn't involved yet, but we see those herpes vesicles kind of starting there on the nose, and that would be somebody that we'd be very concerned about having eye involvement from the zoster. Now, another cause of a red, acutely painful eye is acute angle closure glaucoma. And this is one of the classic ophthalmologic emergencies that we have to know about, and we have to know the treatments that we can administer to help this patient reduce the pressure in their eye. The patient usually presents with, it's an acute onset. It's not a chronic thing or a gradual thing. It happens sort of all of a sudden. They can have a lot of headache. They may have nausea and vomiting associated with it. And the exam is going to be pretty classic. They're going to have a hazy looking cornea. It could look pretty red and angry. They should usually have a fixed sort of mid-range pupil, and they can have an afferent pupillary defect. And we'll talk about what that is in a little bit. So remember that this is basically a closure of the angle where the aqueous humor can't get out, and so you get a big buildup of the aqueous humor inside the eye there. And it has to do, and people have predispositions for this. It can be sort of a hereditary thing. They may have had a history of glaucoma. There are people who are a little bit more at risk for this than other people, but it's usually precipitated by basically a dilation of the pupil. Here's that classic picture of this sort of hazy cornea with this fixed sort of mid-range dilated-ish pupil that's really not reactive, and you see that the eye is really, really red. So this could be a question asked with a visual stimuli and then sort of a what are you going to do about it type of thing. If you check the intraocular pressure, it's going to be elevated. It's glaucoma. So remember what's normal, and this would be usually even over, a reading of 40 if it's really, really elevated. So again, you could have somebody that gets precipitation of glaucoma because they were given eye drops at their ophthalmologist's office to dilate their eye. That can precipitate it, or any condition where that would happen, like dim light, etc. And here are some risk factors there: hypertension, vascular disease, could be familial, diabetics, etc. What is our goal to help them? Well, we want to decrease that intraocular pressure. And just like with orbital cellulitis, when you get an increase in intraocular pressure, you risk ischemia to the retina and sort of decreased visual acuity because of the pressure in this closed space, almost like a compartment syndrome in a way. So you want to decrease that aqueous humor production, and you can do that a few ways. One is with a beta blocker, like timolol, which is a pretty commonly used drug in glaucoma in general. You can also use alpha agonists as well. And then the third thing on the list is acetazolamide, Diamox, which is a carbonic anhydrase inhibitor. Classically, we give this IV. You could also give it PO, but we want to give that Diamox to help decrease the production of the aqueous humor. You can even do things that are osmotically active, things like mannitol, to also try to decompress that pressure in the eye. Now, another thing that's on the list that we can do is a topical miotic, something like pilocarpine that's actually going to bring that pupil down. But we're not going to give that until the actual pressure in the eye is reduced. This comes later down the algorithm, so it's not something that we're going to give up front. And so therefore, we would never give the pilocarpine unless we've already talked to our ophthalmologist, we've got these other treatments on board, we're checking the pressure, it's down now, then you would give the pilocarpine. It's on the list, but it's further down the algorithm. So this is one of those classic eye emergencies where we're going to call our ophthalmologist no matter what time of day, and that's also because we can do some things for it, but they may actually even need a paracentesis of their eye, sort of a reduction of the pressure that way, or some kind of a laser procedure. So there's things that ophthalmologists could do that we can't do to help decrease this pressure in a more acute way. So that's acute angle closure glaucoma. So remember, I just want to go over those really important points because this is a likely thing that could be asked. You want to know that their pressure is going to be increased. It's that hazy cornea with that kind of fixed pupil. The things you can do are timolol, alpha agonists, the Diamox, the acetazolamide as well, and then you're going to call ophthalmology. And those are the main things that you can do for acute angle closure glaucoma. And the pilocarpine is on the list, but further down once the pressure has actually come down inside the eye. Another cause for red eye, which we see all the time and is no big deal, but is a big deal to a patient who thinks they're bleeding in their eye, is subconjunctival hemorrhage. And what do we need to know about that? Just remember to consider coagulopathy. Are they bleeding anywhere else? And you also want to make sure that that red eye that you're seeing is not, bloody chemosis, which is an inflamed conjunctiva in general, which should be circumferential and raised and look a lot different than a subconjunctival hemorrhage. Subconjunctival hemorrhages, we all know there's really no treatment, just supportive, reassure the patient it's going to be okay. This is what I'm talking about when I say bloody chemosis, which is basically also blood inflammation of the conjunctiva, which is very superficial. And you see this also illustrates pretty nicely this picture about the perilimbic area, that area right around the iris, where the conjunctiva goes right up to that area but doesn't go beyond it, and it kind of illustrates that nicely. Okay. Deep breath. This is where we get into kind of the neuro-ophthalmology part. We're going to talk about some of the cranial nerves and the pupils as well, which is a little bit tough. And we're going to talk about APDs and why you get an afferent pupillary defect and the swinging flashlight test and what you have to remember about that. So remember that when we're talking about extraocular movements, cranial nerve 3 is really the main nerve that does most of the stuff in the eye. It is involved with the pupils, it's involved with the extraocular muscles, it's involved with the lid movement. Cranial nerve 3 is kind of the main player when it comes to the eye. However, there are a couple extraocular movements that are not performed by cranial nerve 3, and we have to know what those are. And there's cranial nerve 4 and cranial nerve 6. What does cranial nerve 4 do? Well, it controls the superior oblique muscle, which basically is the muscle that lets us look down, cross our eyes, and look at our nose, look down towards our nose. That's what cranial nerve 4 does. And cranial nerve 6 controls the lateral rectus muscle, which lets us look outwards. So those are two muscles that do other movements that cranial nerve 3 doesn't cover. Cranial nerve 3 does everything else except for those two things. So the way that we learned this in medical school when you talked about this neuro-ophthalmology is this SO4, LR6. It's just a way to remember it. Everything else is 3. Superior oblique is the 4th nerve. The lateral rectus is 6, which helps us look outwards. And everything else is controlled by cranial nerve 3. So there's really just two nerves we have to remember that do specialized thing. Everything else is cranial nerve 3. That's the extraocular movements. Now, when it comes to what controls the eyelid, and this is important when it comes to patients presenting with ptosis and what the differential could be for that ptosis, remember that the 7th nerve helps close the lid. And we know that because of patients who get Bell's palsy and they can't open their eye all the way. So the 7th nerve controls closing the lid. And if you want to think of the 7 as like a little hook closing the lid, that's one way to remember it. I think we kind of know that one. But remember that what helps us open our eye is a couple things. One is the 3rd nerve, that innervates and helps us open our eye, but also our sympathetic nerve system. And that's because if you think about the fight or flight response, if we're having the fight or flight response and our sympathetic system is activated, it helps us open our eyes wider and dilates our pupil to let the light in so that we can run from the lion, right? That's our reactive response. So our sympathetic nerve system plays a role in helping us open our eyes wider as well. So there's a couple things that go in, and one is skeletal muscle, one is smooth muscle. Not important to know which is which. Just to know that the third nerve and the sympathetic nerve play a role in opening our eyes. So that if we get some kind of a cut of our sympathetic chain, or we have a third nerve palsy or some alteration of our third nerve, both of those things being interrupted could cause ptosis and could cause a problem with opening our eyes. So you have to differentiate the two, and you have to look at the other things that those two nerve supplies control. We'll talk more about that. So what controls our pupils opening and closing? Well, this has to do also with our sympathetics and our parasympathetic movements, muscle or nerve systems. So our sympathetics help open our eyes. We talked about the fight or flight. So our sympathetic helps open our eyes. And our parasympathetic then is the opposite. It helps us narrow our eyes, make the miotics, make the pupil smaller. And it turns out that cranial nerve 3 and the parasympathetics kind of run together, and they both help constrict that pupil. So sympathetics help dilate the pupil, and the parasympathetics, which runs with cranial nerve 3 along the pupil, help constrict the pupil. So when we're testing a pupillary light reflex, we're testing a couple things. First, our eye has to see the light in the first place, so that's cranial nerve 2, that's our retina and our optic nerve. But also that pupil is controlled by cranial nerve 3, so we're also looking at testing that when we test our pupillary light response. Remember that when we see people who have anisocoria and have different sized pupils, we have to think about what the differential is for that. Now, there are a certain number of people who run around in normal life with different sized pupils, and so it could be just a normal variant. But one other thing we worry about, of course, is aneurysms, right? And we worry about the aneurysm, and it could be pushing on cranial nerve 3, and that would affect this dilation of the eye. If you basically take out cranial nerve 3, and think about cranial nerve 3 as running alongside the parasympathetics, if you take that out, if you take out the parasympathetics, what do you get? You get unopposed sympathetics in that pupil, which is going to dilate it. And so that's why we think about that compression of the third nerve causing an ipsilateral fixed dilated pupil, which makes us think about perhaps an aneurysm could be pushing on it. I'm going to skip the Argyll-Robertson pupil because we don't really see that very often. It's very unlikely they would ask about that, so I'm going to move on past that. So let's talk about APD, which also is called a Marcus gun pupil, and what the swinging flashlight test is and what it's looking for. And if they have an APD, what is on our differential and why? Instead of just memorizing a list of things that can cause APD, why do you even get an APD? Well, remember that we just said that when we shine a light into somebody's eye, if we're looking with the flashlight, we're testing two things. We're testing cranial nerve 2, the eye has to see the light at all, and we're also looking at the pupillary response. So if I shine a light into this eye, and the eye is working fine, my cranial nerve's working and everything else is working, then what happens when you shine the light in? It tells both eyes to constrict, that there's light coming in, I sense it, so let's constrict. Then I move over to the other eye, and let's say in that other eye, there's something wrong with the retina. Okay, there's something wrong with cranial nerve 2. I have some kind of retinal ischemia, retinal problem, other kind of issue. I'm not sensing the light in that eye anymore. And so what happens if I'm not sensing the light is that the pupils aren't getting that kind of input anymore, telling them to constrict. And so they basically go back to normal, which looks like they're dilating. But really what they're doing is just going back to normal because they're not getting that afferent input. They're not sensing the light. So it tells you there's something wrong with cranial nerve 2 in that eye that you're shining the light in when the eyes go back to normal. And so that's something to think about. So what kind of processes could affect the retina in that way, that you basically don't have it sensing the light? Well, I want you to think about optic neuritis. That's one really to think about. Think about multiple sclerosis, and I know Dr. Sokolov talked about this in the neuropsych section. Think about optic neuritis. Also think about things that are causing that increased pressure in the back of that eye that's causing maybe some retinal ischemia, things like glaucoma, or things like a tumor, something that's causing pressure, that's decreasing the blood flow to that retina, and it's not sensing the light. And that's really what the afferent pupillary defect tests for. So you see images like this, where they show you the pupils are equal, then you show the light onto the good eye, the afferent input is increased, cranial nerve 2 is fine, retina's fine, tells the pupils to constrict because there's light coming in, perfect. Then I move the eye to the light to the bad eye, where there's some kind of a problem. Now the afferent input is decreased. The retina's not working, it's not sensing the light. And so the pupils look like they dilate. Really what they're doing is returning back to normal because they don't have that afferent input. And that's another little diagram showing you that. So that's kind of reviewing, sort of understanding what the APD is and why your differential would be what it is when you really worry about what's happening to the retina back there. And that's another image sort of illustrating the same thing. So there you go. There's your little like swinging flashlight test where that's where the pupils are small, that's shining into the good eye. Then we move over to an eye that's the cranial nerve 2 is not working, something's wrong with the retina, and so the eyes look like they dilate, they go back to normal because they're not getting afferent input. So when we talk about pupillary syndromes, and we just talked about how the sympathetic chain innervates the eyelid, it helps us open our eyes wide, it helps us dilate our eyes so that we have our fight or flight response, and it also, the sympathetic chain, also helps us sweat as well, kind of stimulates the sweat glands as well. So if we take out the sympathetic chain, and what can do that? Can be, where does the sympathetic chain run? It runs in the sort of cervicothoracic region. So if we have some kind of a tumor in our neck or our apex of our lung pressing on that sympathetic chain, or we have some kind of trauma, et cetera, we take that out, then we lose that sympathetic input. And so what do we lose? We basically have the loss of the elevation of the eyelid. That's what sympathetic does, so we get ptosis. We have the loss of that dilation of the eye, so we get miosis because of that. And we get dry facial sweat glands. We get the anhidrosis, which they'd have to tell you the patient doesn't have sweat on that side. And that is Horner's syndrome, when you take out the sympathetic chain. So there you go, there's the ptosis, you see the constricted pupil because you don't have the sympathetics, so you'll have the unopposed parasympathetics, and they'd have to tell you that the face is dry on that side. And that's Horner's syndrome. As opposed to a third nerve palsy. The third nerve also innervates the eyelid, so they also have ptosis. They can't open their eyelid, but they have a dilated pupil because remember the cranial nerve 3 runs with the parasympathetics. So when you take that out, you have unopposed sympathetics and you have a dilated pupil. And because cranial nerve 3 does a lot of the extraocular movements, you have unopposed lateral rectus movement as well. So the eye is looking out. And so that is what cranial nerve 3 palsy would look like. So this is just another review going through those different things, and you got to review those sort of different syndromes that can cause ptosis. And this is also, it comes into, if you had your cranial nerve 6 out just by itself, then you couldn't look laterally with one eye. Everything else would be intact. You just can't look laterally with one eye. Eyelids are fine, everything else is fine, and that would be an isolated cranial nerve 6 palsy. This is kind of a money slide right there. Put a star around it, circle it, put your highlighter over it. This kind of summarizes all of that I just went through. What Horner's would give you, taking out the sympathetic chain, what a third nerve deficit would give you, and then what a sixth nerve being out by itself would get you, and what they would look like. And so differentiating those things that can give you ptosis is important when it comes to these ophthalmologic syndromes. So let's move on in our last 20 minutes or so into vision loss, and then we'll talk about some trauma of the eye. In terms of visual fields and visual field cuts, what do you need to know for the exam? Because there's a lot of possibilities. There's only a couple really important ones to know. One, certainly, if you take out an optic nerve, you'd have monocular blindness. That's true. But what about a couple other things? What about when you get one of those pituitary tumors sitting right there? That gives you a visual field deficit, doesn't it? If you have a pituitary tumor sitting there, what you get is a bitemporal vision loss, a bitemporal hemianopia or anopsia. So if you have a pituitary tumor sitting there, think about that. Right in the middle, you basically get a field cut on the outsides, on both temporal visual fields. That's a bitemporal visual loss. That happens when a pituitary tumor is sitting right there in the cella. The other main visual field loss to know happens when patients get a stroke. And we know that because this is why their eyes will deviate to one side with certain types of stroke. So, for example, if you have a left-sided stroke, what happens is that usually your vision is preserved on that side that you had the stroke. You've taken out the other side. So your vision's preserved on the side where the stroke happened, meaning that your eyes drift to that side where the vision is preserved. You have a visual field cut on the other side. So your eyes go to the part where they can actually see. So when you see eyes deviated to one side in a stroke patient, they're looking to the side where the stroke happened because they have a visual field cut on the other side. They look to the side where the stroke happened. So those are really the three types of visual field loss you have to know about. The kind where you get the pituitary tumor and you take out the temporal parts of the visual field, and then also when you have a stroke and the eyes go to the side where the stroke happened, because that's where the preserved visual field is. So the eyes tend to go to that side. That's the most common visual field deficit in stroke. Looks to the side the brain lesion is on. Now, when patients come in with one side of vision loss, monocular vision loss, there's a couple things we have to think of. One of them is that all of a sudden you cut off the blood flow to that retina, that you have a central retinal artery occlusion. This is sudden, it's painless, it's monocular, and it's basically an interruption of the blood flow to that retina. Now, it can be transient. It can be what we call amaurosis fugax, right, where you have a little clot that basically went off to the ophthalmic artery, and then it dislodged and you get your vision back. And you want to think about this syndrome as equivalent to a TIA or a stroke, because it's really the same etiologies. It's usually a fib or something causing some kind of showering of emboli, and you basically get one of those emboli that go to this artery. So when you think about CRAO, when you think about the arterial blood supply being cut off, think about it like a TIA, amaurosis fugax, or like a stroke. Of course, you would get an afferent pupillary defect on that side, because if you have ischemia to that retina, it's not going to be able to see light, and you're going to have an APD. What is that eye going to look like if you don't have blood flow to the retina? Well, it's going to look pale, and you're going to have a fixed dilated pupil because it's not sensing the light. And the macula has a little tiny cherry red spot, and that's because it happens to have some other collateral circulation. So let's look at what that looks like. Now, in terms of if you suspect a CRAO, you suspect an arterial blood supply cutoff to the retina, you want to think about it like a stroke. So not only are you going to involve an ophthalmologist, but you have to also do a neuro workup for that patient, just like you would if they had a TIA type of thing. So you have to also think about involving a neurologist in this person's care, or their PMD to work up a TIA kind of thing. So if you have a CRAO, and you can think about this if you want, like an arterial obstruction to a limb, that you have a very limited amount of time to solve that problem, and there's not a whole lot that you can do. You can try to lower the intraocular pressure to basically allow increased blood flow to the back of that eye, and hopefully maybe the embolus will move. You can massage the globe to try to dislodge the embolus. That's one thing you could try. You could have them breathe into a brown paper bag to basically increase their PCO2, and that might dilate the retinal artery. You're doing all of these things to try to promote blood flow to the retina. You can also consider the things that we use to decrease the intraocular pressure back with glaucoma, things like Diamox, to try to decrease that aqueous humor production and promote blood flow to the back of the eye. And you're going to involve your ophthalmologist because they could be doing something like sucking some of that aqueous humor out to decrease that pressure in the back of the eye. You have a very short time window to restore vision, about 90 minutes, if you cut off the arterial flow to the retina. So this is a big deal. Now, in terms of the visual stimuli, this beautiful fundoscopic picture, if you see a very pale retina like this, you should think, God, it's really not getting any blood flow. And so that's an arterial obstruction. So it looks like this very pale retina. You may have some sluggish flow in the retinal arteries, causing this boxcar look to the retinal arteries. And you see this little cherry red spot of the macula because it gets some special collateral circulation. So this should make you think, wow, it looks like this retina is not getting blood flow. Think about CRAO. And if you think about CRAO, you're thinking also, this is like a stroke, this is like a TIA, I need to also work that up as well, in addition to trying to get blood flow back to that retina. Here's another picture of kind of what that might look like. Again, you just don't see a whole lot of circulation to the back of this eye. It looks very pale, looks very washed out, because it's got an arterial obstruction. Now, the other type of painless vision loss that can occur happens on the venous side. And so if you obstruct your central retinal vein, this also, and you basically create decreased drainage of the blood flow to the eye, you get a backup of blood flow, you get edema, and you can get some hemorrhage. Now, usually, if it's a venous obstruction, this would be a more gradual onset, not like the CRAO, where it's sort of a sudden onset. You cut off the blood flow all of a sudden. This is more a backup of blood flow. If you want to think of it like a DVT, it's not a DVT, but if you want to think of it like how it backs up the blood flow and the leg gets swollen and red, it's sort of the same in the back of the eye. It's basically backing up and causing some hemorrhages, et cetera. Now, there's not much you can do for this in the acute treatment. You can consult ophtho urgently. It's not an emergent consult. There's nothing that they can do about it, emergently. Usually it has a pretty good prognosis. You might consider something like aspirin to kind of decrease that platelet stickiness. And you will see the blood and thunder appearance of the retina, which is basically the backed up blood flow, the venous blood flow in the back of the eye. And so you just see these kind of hemorrhages, and that's why they call it blood and thunder. This eye looks like there's a traffic jam and the blood can't get out. And that's a CRVO on the venous side. Again, the onset of the vision loss would be more gradual, not as sudden onset. So that's a CRVO. There's little hemorrhages everywhere. It looks kind of a mess. That's blood and thunder. It's on the venous side. Now, another cause of vision loss can be optic neuritis, which we already mentioned and was mentioned in association with multiple sclerosis. This usually has some pain associated with it because of the inflammation that's involved here as well. And they can often have painful eye movements. And they will have an APD in that affected eye because they have papillitis. They have inflammation of their retina in the back. They can also have loss of color vision, maybe one of the unique parts of their presentation. So when you see or get reference to you could be a young person, Peter talked about this, a young woman who might have vague neurologic complaints, but they could have this visual complaint, which is a painful eye with some loss of vision. Think about optic neuritis and multiple sclerosis. This is a picture of papillitis, or some basically edema of that macula in the back, and so that's optic neuritis in terms of a fundoscopic view of it. And they could have loss of color vision. Now, retinal detachment is something we also think about when a patient presents with vision loss as the retina tears. This is something that's in our differential frequently, and the vitreous humor, the liquid, gets in there behind the retina and starts tearing it away from its blood supply. They can have vision loss as well. And there's a bunch of risk factors for retinal detachment, which are listed here, including having had a retinal detachment before. Typically, this vision loss is painless, and what's important to know about retinal detachment is what are the buzzwords that you gotta know. If they mention this in a vignette, you have to know these sort of buzzwords. If they describe flashes and floaters, if they describe a lowering of a curtain over the visual field, they're trying to get at retinal detachment as the possible diagnosis. Floaters, flashes, lowering of a curtain are classic words describing a possible retinal detachment. And the fluid gets in there and starts pulling the retina away. If you actually looked at the back of the eye and you could see it, which we can't always see the full retina, which is why we have to refer these to an ophthalmologist, you may see some gray retinas with some folds as the liquid's getting back there, and they can also have vitreous hemorrhage as well. When do we consult ophtho emergently with these? Well, basically, if they have any vision intact, then we're going to talk to ophtho right away because their macula still may be attached. It may be a MAC-on retinal detachment, and that is something that could be intervened on. If they've already lost their vision, there's really not a good prognosis for that, so it's less emergent. We have a hard time ruling this out ourselves by our direct fundoscopy. They can do more indirect fundoscopy and look at the corners of the retina better than we can. However, we now have another tool to look at this, which is ocular ultrasound, to look for retinal detachment with ultrasound as well. So it's reversible or time sensitive, especially if they have some vision intact. If the vision is already gone, it's less emergent for the ophthalmologist. So the fundoscopic picture could look like this, where you see these sort of retinal folds, and this is kind of the fluid sort of tearing the retina away. Another cause of vision loss to consider is temporal arteritis, and you have to think about this in the right patient, in the right vignette. This is going to be an older patient, right? It's going to be an older patient who's complaining of vision loss in association with some kind of a new headache on one side, a unilateral headache. About half of them will present with some kind of impaired vision, so we have to suspect this. It can also present as an amaurosis fugax type of thing, a transient vision loss. And classically at ABEM General, the patient would have some sort of temporal artery tenderness on palpation in the description. And this is important because if we recognize it early and we start steroids early, we can preserve vision. So we have to know how to recognize it, and it's a clinical diagnosis. There are some criteria that the American College of Rheumatology puts out for temporal arteritis, which we now really call giant cell arteritis. You have to be over age 50. It's got to be a new onset headache. They may have an elevated ESR, all these things you know. Remember that they may also give you a clue in the history of this patient that they may have painful chewing. And that's because the vasculitis also can involve the arterial supply to the muscles of mastication. So part of their history might be painful chewing, and it's part of the same process. What's important to know about it is that you may have warmth and tenderness over this temporal artery. They may have an APD because of this vasculitis to the blood flow of the eye. And if we suspect it, yes, we're going to talk to an ophthalmologist, but this is someone we're going to start high-dose steroids in that really can be vision preserving for that patient. If their symptoms have been going on for a while, they get IV steroids for this, and that's why it's important to recognize. Older patients, new onset unilateral headache, maybe some vision loss, we clinically suspect we're going to start IV steroids to decrease that inflammation, that vasculitis. Okay, let's move on to some trauma of the eye and kind of close it out here. Now, if I ask you if you want acid or alkali in your eye right now, which one would you pick? You'd pick the acid, right? The acid is not as bad as the alkali. The alkali, they like for some reason us to know this pathophysiology. Alkali causes liquefaction necrosis. That doesn't sound good. Versus acid, which is coagulation necrosis. And I kind of remember those sometimes. The acid has a C in it, so that's coagulation necrosis. And the alkali has an L in it, so that's liquefaction necrosis. But the alkali, that liquefaction, of course, that's deeper than the coagulation, which is not as deep. So alkali is worse than acid. What do we do for chemical exposures of the eye if they do get one of these substances in the eye? Well, our whole job is to try to get the pH back to normal. So we're going to irrigate that eye and check the pH until we get the pH back to around 7.4. And that's really the goal of what we can do. What might the picture look like? They could have sort of an opacification. They could have sort of these corneal burns, and they'd have to give you some story of some exposure, and your treatment would be irrigate and check the pH. There's another picture of kind of an opacified eye. Now, hyphema, in terms of traumatic injuries to the eye, if you get red cells that layer out in that anterior chamber, that's called a hyphema. And usually this happens because of some kind of small vessel rupture. This can also happen without trauma if they're on some type of anticoagulation and they get a spontaneous bleed from that. There are a bunch of complications that can happen from a hyphema, and in particular, one that can happen is as that clot starts to settle in the anterior chamber and that clot starts to retract like any other clot, you can get a rebleeding that happens in a delayed fashion, and that's kind of the most feared complication of a hyphema. As that clot retracts, basically bleeding happens again, and that's what we worry about. Hyphema can be small and sort of a little layer of red cells, or it can be the entire part of the eye, which is called an 8-ball hyphema when it really goes all the way up. These are kind of small hyphemas. What do we do for a patient with a hyphema where they're going to have bed rest? We elevate the head of the bed. We often protect the eye. We're going to talk to an ophthalmologist. If they are having increased intraocular pressure from this, we're going to treat it like glaucoma. We're going to avoid any anticoagulants. And if it's a very small bleed, a reliable patient, you could treat this as an outpatient. If it's more of an 8-ball hyphemia, high-risk patient, very anticoagulated, that might be someone who gets admitted and treated that way. There's a picture of an 8-ball hyphema involving that whole anterior chamber with red cells all the way up. The other thing that we have to know in terms of visual stimuli for ophthalmology is the signs of a possible globe rupture. Someone who's had trauma to the eye and we're worried about an open globe. And there are some classic signs of open globe that you have to be able to recognize. And here they are listed here. Specifically, teardrop-shaped pupil, flat anterior chamber. You're going to have maybe even uveal prolapse, the sort of black part coming out. And if we put fluorescein in their eye, because they've got an open globe and their aqueous humor is just rolling out of there, it's going to wash that fluorescein away, and it's going to look like a little river coming out, and that's Seidel's sign. And these could be great visual stimuli questions. What do you do if they showed you a teardrop-shaped pupil and they say, what do you do? This is one of the circumstances where we actually put a metal shield on the eye to protect it. We don't put any pressure on that eye, no tonometry. We're going to give them IV antibiotics, and we're going to update their tetanus and analgesia. We don't want them to be throwing up and increasing their intraocular pressure. We're going to image with a CT orbit, and we're going to talk to our ophthalmologist right away. So we know what we're going to do for that potential open globe. Here are some visual stimuli to remind you of those different classic signs. The teardrop-shaped pupil, you also see a corneal laceration there. There's another teardrop pupil. There's sort of some prolapsed iris coming out with the teardrop pupil. Obviously, this one where we're working about an open globe, this is not subtle. So any kind of penetrating globe injury, we're going to be worried about this, shield, CT orbit, all those other things to do to treat an open globe. Corneal abrasions we see all the time. I don't want to spend a lot of time on this. You guys know what this looks like. Just remember that if you see a patient who has that fluorescein stain and it looks like that ice rink sign where that foreign body's been going around and around, you got to evert those lids and you got to look for that potentially hidden corneal foreign body. And contact lenses, don't forget contact lens, Pseudomonas. Contact lens, Pseudomonas, they go together. There's that ice rink sign, and there you see that sort of going around and around. We got to evert those lids and make sure we're not missing the foreign body if we don't see it. We're going to give analgesics. We're going to, make sure they're comfortable. We're not going to give them topical anesthetics for home use at ABEM General right now, although we know that's probably mostly a myth, but we're not going to do that at ABEM General. We're going to tell them not to wear their contact lenses, update their tetanus, and most of these get better on their own with some analgesia. And they may have some recurrent pain down the road, and you can see sometimes a recurrent corneal erosion in a delayed fashion. If it was a metallic foreign body, we have to worry about the rust ring that needs to be removed a few days later as well. Okay, and remember that if it's a metal-on-metal mechanism, they were a welder, some kind of metal-on-metal, and we have a metallic foreign body that went in the eye at some kind of possible high rate of speed, we have to worry about intraocular foreign body and potentially open globe, and so we have to be suspicious of that as well. Here's a picture of that little rust ring that's going to need to be removed a few days later. And the last few things are to talk about briefly orbital blowout fractures, somebody who's also had blunt trauma to their eye. Remember that in the orbital walls, there are a couple walls that are particularly thin. One of them is the medial wall, and that goes into the lamina papyracea. And if you get a fracture there, you can get basically some orbital emphysema from those air cells, and you can also get epistaxis. And this would be in a patient, for example, who may not even have any nasal trauma, but they have a bloody nose. Think about a medial wall fracture causing that. Also, if they have an inferior wall fracture and their orbital contents could herniate through that inferior wall, remember that that can trap the inferior rectus muscle. And what that does is it entraps that muscle and they can't look up. Their upward gaze is inhibited. So it's the inferior rectus muscle that gets trapped as the orbital contents go right down in this part, and they can't look up. They can also have infraorbital nerve involvement as well. We're going to image these mostly with CTs these days. It's a much superior imaging technology. Every once in a while, if you only had x-rays where you are, you could do plain films, and you'd get that Waters view and look for the teardrop sign, which is the orbital contents in that infraorbital space. Here's a picture of that teardrop sign of those contents coming through that inferior orbital floor there, and you may even see an air fluid level on that sign. And here you see a CT showing those muscle bellies there and that orbital contents in that sinus space, and maybe entrapment. And remember, what would on your physical exam, they wouldn't be able to look up. There you go. Limited upward gaze. And then the last couple things, retrobulbar hemorrhage. If you do have bleeding into that closed space of the eye, in the back of the eye, we talked about how that's all closed off. That can also create increased intraocular pressure, which could then create ischemia to the back of the eye. So many things that can do that. And that patient could then have decreased visual acuity because of that ischemia to the back of the eye. What are we going to do about that? Well, we've got to release the pressure. We've got to promote blood flow to the back of that eye. And that's where lateral canthotomy and canthelysis come into play. We can also, you could try medication to decrease the intraocular pressure theoretically, but really it's not going to do that in a hemorrhage type of situation. So it's going to be a mechanical release of that pressure. And the goal of that is to restore blood flow to the back of the eye and release that pressure. Retrobulbar hemorrhage you would see on a CT, but clinically you could see proptosis, and the patient could complain of decreased visual acuity on that side. There's a bunch of lid lacerations that you have to refer. Remember, there's a list of those things that you're not going to fix. If you're worried about the tear ducts, if you're worried about the very, very margins of the eye, these are things that you're going to refer for repair. I'm not messing with this lid laceration. That is getting referred. That is out of my scope of practice. There are things we have to know that are out of our scope of practice. So if you see that tear duct that might be involved, that is something that you want to refer for repair so you don't mess with the tear drainage that the eye has. Canalicular laceration, out of our scope of practice. And the last two slides are on papilledema. Just remember that papilledema, swelling in the back of the retina, is reflective of increased intracranial pressure, and so it's a bilateral process. The optic nerves, cranial nerve 2, are our way of seeing into the central nervous system. And if you have increased intracranial pressure, you can get papilledema in both eyes. There's a bunch of differential for that. You'd see this optic disc swelling on your fundoscopic exam. And that's what papilledema would look like on a fundoscopic exam. And that brings us to the end of ophthalmology. Thank you very much. Dr. Mathieu is up.